Okay, and welcome to the Davies Use Case webinar being presented by Sparrow Health on anticipating and preventing adverse drug events. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who utilize health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology care delivery. It is my pleasure to welcome our speaker for today's webinar. First, we'll have Chris Nimitz providing an introduction to Sparrow Health. And for the main presentation, we will have Ashley Myers and Craig Havacan as the presenters. So Chris, Ashley, and Craig, I will turn the presentation over to you, and you can begin when you're ready.
But first, I want to talk about Sparrow Health System. We're in the heart of Michigan. We have around 700 beds, 30,000 inpatient discharges, 8,000 surgeries, inpatient about 13,000. We do about 4,300 births a year. We are a level 1 trauma center. We are a 3-hospital system where we have 2 acute access hospitals and 1 long-term care hospital. We have about 60 to 70 ambulatory clinics, over 400 providers. You can see our outpatient visits. We have roughly 600,000 a year, and a variety of specialties and services that we serve the community within the heart of Michigan. And you can see several listed here, from our behavioral health to family medicine to pediatrics, urgent care, and even a wound clinic that we provide hyperbaric clinical care to our customers. So that's a little bit about Sparrow, and now we're going to talk about our program.
Hi, my name is Ashley Myers, and I'm a clinical nurse educator at Sparrow Hospital.
And I'm Craig Havacan. I am an application analyst with Sparrow Hospital.
Today, our webinar is discussing anticipating and preventing adverse drug events, specifically decreasing the need to rescue hospitalized patients from opioid-related complications. As we all know, we are currently amidst an opioid public health emergency. In fact, Trump declared a national emergency in 2017, and to put this into perspective, 142 Americans are dying every day. We are enduring the death toll equal to the September 11th attacks every 3 weeks in America. Opioid administration in hospitalized patients too often harms patients that it's intended to help. We measure harm by the administration of an opioid reversal agent while the patient is in the hospital. That medication is naloxone, otherwise known as Narcan. Our data suggested that we could do better related to our naloxone administration. And we know that if we can identify risk factors and place interventions in place for patients at risk for opioid-induced respiratory depression, that we can keep our patients safe.
The group recognized that there were validated tools available that could be used to identify patients who may be at risk for inadvertent overdoses causing adverse drug events, or ADEs, that could alert the caregiver prior to needing naloxone. It was identified that the tool needed to be well designed to improve our clinical outcomes and decrease the cost of care. Lastly, it was noted that we currently did not have these tools nor the current workflow to use them.
We have a number of drivers to take action during the time frame of our project implementation. First of all, as we mentioned before, we are amidst an escalating national opioid crisis, and Michigan is ranked 10th in opioid prescribing and 18th out of all states in opioid-related deaths. Additionally, the Joint Commission issued a Sentinel event alert specifically focusing on the inpatient administration of opioids and the harms related to it. At the same time, the American Society for Pain Management Nursing issued guidelines which outlined the risk factors for opioid-induced respiratory depression, as well as interventions that could be completed to decrease the risk. Lastly, our hospital was lucky to participate in an MHA Keystone Center-related prevention initiative focused on opioid adverse drug events. So we had a lot of drivers to take action around the initiation of our project. Our frontline nurses took the lead in this project by identifying the adverse drug events related to opioid administration at our hospital. We, as an interdisciplinary team, invited our pharmacy colleagues and our IT colleagues to help us look at this quality data, analyze it, and identify trends for improvement. What we found was that nearly 1% of our patients that we were treating with opioids in the hospital were experiencing an opioid-induced respiratory depression event that required a naloxone rescue. To improve this, we set our goal to decrease the rate of giving or administering naloxone by using a variety of tools. First, we wanted to leverage our governance, our leadership, our clinicians, and our IT colleagues. We knew we needed to develop better policies and workflows, introducing the lean methodology, and then lastly, incorporating IT technology into our project implementation.
This was the SPRN, Sparrow Pain Resource Nurse Committee group that initially took this on. An analyst from IT was involved in this committee from the beginning and continues to be part of it today. SPRNs partnered with pharmacy and began analyzing our naloxone rescue data in 2014. They found 104 ADEs related to opioid use. These were reviewed to note drug, dose, order set, patterns, and opportunities to improve. Another example of using IT and knowledge as a solution to a problem, during this analysis, we identified the issue with fentanyl patches. The SPRNs realized there was nothing to inform the caregiver when a patch would reach its peak effectiveness. The group recommended and implemented a fentanyl patch peak assessment work list task, which also played a part in our ability to reduce ADEs with opioids. At the time, we did not have the necessary reports to extract the data accurately capture what we needed. It was a manual process, and the reports we could use were not all inclusive or run consistently, so our ADEs may have been underreported. Now, our data analytics team worked with SPRNs to come up with more reliable and comprehensive reports. They now can be run retrospectively to compare a true baseline. It was found we actually had 179 ADEs in 2014, and our rate was 0.72%. In 2015, at the time we initiated our intervention, November of 2015, our rate was 0.73% and on an upward trend. As we just mentioned, the rate for naloxone use was actually showing an increasing trend leading up to our implementation. MOS was our intervention, which was new practice and documentation, and therefore was at a 0% baseline documentation rate.
So given our interdisciplinary group, the data that we had showing that we knew we needed to improve, and also the knowledge tools such as the guidelines, we formulated a project description and a goal. Our overall project goal was to measure acutely ill adult inpatients and does an EMR integrated risk assessment tool that is aimed to prevent opioid-induced respiratory depression. This implementation of this tool within accepted nursing workflows decrease the rate or incidence of opioid-induced respiratory depression as measured by naloxone use. Our goal was to increase our inpatient naloxone rescue rate to less than or equal to 0.65%. This benchmark came from 7 Michigan member hospitals, all that have over 550 beds and are like hospitals. Our goal is not to have 0%. Some patients will require naloxone, even with best practices, but our goal is always to decrease that harm. So we're focusing on appropriate use, identification of risk factors, and prevention monitoring. Naloxone administration is really considered a never event. Again, as I mentioned, our goal was to decrease our naloxone incidence to less than or equal to 0.65%. When we break down our benchmark, the numerator is the number of patients receiving opioids and received the naloxone rescue medication, and our denominator is the number of patients that received any opioid. Again, that's via any route. We aligned this with multiple collaboratives and initiatives.
The SPRN decided on the tools to use. They chose to use the POS, which is the Sparrow Opioid Sedation Scale, to monitor sedation levels with opioids, and the MOS, Michigan Opioid Safety Score, which, as you will see, is a multi-informational scoring tool. We also decided to use EPIC since it was our EMR in use, where our care is documented and decision supports are given. This would also give us the opportunity, if successful, to share with other EPIC organizations.
So first we had to decide what good looks like. And again, we reviewed the literature among sentinel event alerts and other guidelines that were available to us and identified, based on the literature and other hospital best practices, what we could incorporate here at our hospital. Like we mentioned, we incorporated people, processes, and technology. We identified our best practices and utilized a SWOT analysis, which is strengths, weaknesses, opportunities, and threats, to help determine what best practices other hospitals had utilized that we could learn from. For example, we contacted Beaumont Hospital and asked them how their implementation went on paper. And so we could learn from their processes to guide our workflow. Additionally, we had to communicate for key stakeholder buy-in, and one example of that was creating an executive summary to harness the resources necessary.
Our next step was to build solutions in the EMR. We built the assessments, scales, and scoring tools, care plans, and CDS tools and displays, all within the policy-supported workflows.
Then we had to test our build and test it some more and test some more until we had a version or a workflow that the nurses felt like would fit, was efficacious, made sense, and easy to do. We had to address our policy implications. We also participated in an FMEA. An FMEA stands for a Failure Modes and Effects Analysis, which is an activity where we were preoccupied with our intervention failing, and so we spent a lot of time focusing on the potential failures of our project and trying to identify any barriers and put things in place so that we could have a successful and sustainable rollout.
Our last step was to go live and perform PDCA. We worked with nursing leadership to get sign-offs. We trained the users on workflows and purpose of the tool, put it into practice, measured and monitored outcomes and effectiveness, and adjusted as needed.
So what tool did we use? We used the Michigan Opioid Safety Score, otherwise referred to as MOS. This tool was originated from a physician, Dr. Soto and Dr. Yaldu, at a hospital in Michigan in response to the guideline recommendations. As there were no validated tools available, to assess risk for opioid-induced respiratory depression. This novel tool combines health risk assessment, respiratory rate, and a modified version of the sedation scale that was mentioned earlier, the Sparrow opioid-induced sedation scale. The first category of health risk goes through 4 different groups of risk factors for opioid-induced respiratory depression. Group 1, for example, has a risk factor of snoring, BMI greater than 40, or obstructive sleep apnea. The second category, respiratory rate, and the third category, sedation level, those are both documentation categories or assessments that are documented on frequently throughout the patient's visit. Lastly, when the MOS score is calculated, the nurse will get a number, a MOS score. 0 or 1 equates to safe, meaning that the nurse is safe to proceed with opioid dosing. This tool does recommend or suggest multimodal analgesia throughout. You'll see a MOS score of 2. Now we're concerned about the patient's risk level, and we're putting into place interventions to decrease that risk. And then it will escalate to a MOS score 3 or 4, which recommends decreasing the opioid dose. Lastly, if any patient is over-sedated at the time of assessment, it will automatically tell the nurse to stop all opioids and notify the primary physician. As mentioned before, we participated in a strengths, weaknesses, opportunities, and threats analysis of the rollout on paper that Beaumont Hospital completed with their MOS deployment. We really wanted to learn what went well and what didn't go well with their rollout, and how could we learn from their mistakes. So what did we learn? We learned that we needed to put this in the EMR and decrease double documentation. That was really our take-home piece of information, as Beaumont Hospital was still using on paper. And so the other big weakness was that the turnover of nursing on that unit presented a barrier as well. So we used that information and knew that we needed to have a good plan for training ongoing, as well as go live and implementation, and that our focus and efforts needed to be on decreasing double documentation and building in our EMR.
The next step was to effectively build this tool within Epic and get it to work with minimal additions to the caregiver's workflow.
Once we had completed our data collection, our project goal planning, as well as a SWOT analysis, once we have really built our MOS in the EMR, we wanted to test our MOS implementation plan. And we did this by completing a failure modes and effects analysis. We pulled in a large group of key stakeholders and went through every step of our implementation plan and identified where we could potentially fail. A few things of note: we identified that there were multiple other hospital initiatives that were going on at the same time, and we needed to prioritize where this project rollout would fit along with all others, and that also informed our timeline. Additionally, we focused on making sure that our EMR build was appropriate across applications and other disciplines. We also learned that we needed to have some just-in-time education and go-live support, which was really one of our big take-home items from this FMEA, was to develop a go-live support plan for the day and week of implementation.
We came up with a standard process for this documentation, as you will see with the videos. When a patient is admitted, the nurses will document a baseline risk score along with their routine assessments, which include a sedation level and a respiratory rate. If an opioid is ordered, the patient will be reassessed per policy for the risk assessment and routinely for sedation and respiratory rate. Tasks were created to require a reassessment of sedation and respiratory rates after the administration of an opioid. Once documented and filed, custom formulas and rules assign MOS points, which are then totaled and displayed by our MOS scoring tool. If the score is less than 2, the assessments are to continue per normal assessment policies. If it is greater than 2 and less than 5, the nurse will get a best practice advisory if there is no current care plan for risk of respiratory depression. This will create a care plan for the nurse to monitor the patient more closely while they are receiving opioids for pain control. The same BPA will fire for a score of 5 or higher, but the nurse is also alerted to stop giving opioids, notify the physician, and to increase monitoring. The workflow would then restart back to the question of whether there are opioids ordered or not. The caregivers have tools on the patient list to follow their patient's risk levels. On their list, there's a column that gives the nurse an up-to-the-minute MOS score seen in the upper right corner of the slide. The score recalculates every time one of the components documentation is filed. Below the patient list, there is a report that caregivers can review to see how the score was derived and what to do based on the score. On the bottom left, you can see the documented pieces that contributed to the MOS calculation. At the bottom right of the slide, you can see how the colors of the report match the colors in the column, making it easier to identify the level of severity of the score and what actions need to be taken based on the score. On the right, you can see a report that the nursing managers and rapid response nurses have the ability to run for their units that not only show them the patient's scores, but what was documented, when, and many other pieces that can be modified for your institution's needs. On the left, you can see a best practice advisory that fires when a patient has a MOS score of greater than 2, has an active opioid order, and does not have the required care plan template active for the patient. If they click Do Not Add, an acknowledge reason is required to be able to click Accept.
When the best practice advisory alerts the nurse to the patient's risk level, it will recommend a risk for respiratory depression care plan. The care plan is derived from the American Society for Pain Management Nursing Guidelines on opioid-induced respiratory depression. For example, if a patient has risk level, you can increase the frequency of monitoring related to sedation, respiratory status, and pain, or you can increase the frequency of monitoring associated with intermittent to continuous monitoring. So for example, intermittent pulse oximetry and continuous ECG might be elevated to a continuous pulse oximetry. If the patient is on supplemental oxygen, they might be elevated to continuous pulse oximetry plus continuous capnography monitoring. So how are we doing? After we implemented our best practice of the Michigan Opioid Safety Score and continued to monitor compliance of our Michigan Opioid Safety Score documentation rates, in November of 2015, when we implemented MOS for the first time and completed mandatory education, you'll see that our increased compliance related to MOS documentation occurred, at which point we had a drop in compliance and we chose or elected to educate our nurses again. And you'll notice that in 2017, near the end of the year, we chose to make MOS documentation required. No, we didn't. I'm trying to look at our
July.
In July of 2017, we required risk for respiratory depression related to opioids using the MOS score as our institutional policy. And in January of 2018, we required that documentation in our EMR. You'll note our compliance related to documentation of MOS increased considerably after our policy and required documentation components were put into place. So did we meet our goal? If you remember or recall that we had a goal of decreasing our naloxone rate to less than or equal to 0.65%. Again, those are the patients that received naloxone and an opioid. In 2014, Craig mentioned that our mean Narcan rate was about 0.72, and that was about 179 patients per year receiving naloxone. That equaled out about a mean of 14.9 patients per month. As you can see, we've trended this and tracked this data over time, and we've continued to make a decrease or decrease our incidence of naloxone. In 2015 was our implementation year in November, and so 2016 was our first year where we could start to track or correlate our outcomes with our project and implementation. So our Narcan rate was 0.69, which was a 3% decrease from the previous year. In 2017, we continued to sustain that decrease down to 0.51, which was actually a 23% decrease from our baseline. That is about 9 patients per month as compared to almost 15 per month. We have trended through 2018 year to date and continue to stay on track to sustain our decrease over time. And again, we average about 9 patients per month.
So how is this value derived shown with our patient outcomes? The overall trend of ADEs is continuing down. You can see there are spikes in the data at the end of each year. There tends to be an increase in elective surgical cases prior to the resetting of copays on the patient's insurance. These patients tend to receive more opioids than the general medical patient, which could explain the increase in risks of ADEs. Here's a comparison of the two slides where you can see a correlation between the increases in documentation compliance and a resulting decrease in the ADEs requiring naloxone. This shows that this has been clinically a very effective tool.
We were also able to calculate the cost avoidance as a result of our clinical improvement. We went to the literature and we were able to average out our adverse drug events. The cost related to an adverse drug event is about $14,000 to $20,000 as far as the range goes. And so for every incidence that we have avoided giving naloxone, we are saving our institution between $14,000 and $20,000. So we were able to calculate that cost avoidance over on the right-hand column from year to year, and you'll see that we have sustained or effectively avoided additional cost of $874,000 to $1.22 million. So our estimated cost avoidance in 2016 was around $308,000 to $431,000, and overall, since we've implemented the Michigan Opioid Safety Score, we have harmed 142 less patients, and we have avoided between $1.8 million and $2.5 million of costs.
EPIC has picked up our MOS build as an essential clinical program, meaning that this is a highly effective tool, and EPIC recommends it be implemented by other organizations. The build details can be found by searching MOS on EPIC's user web. We have also been informed through EPIC representatives that MOS was being considered for foundation build.
Additionally, our hospital has been recognized from the Patient Safety Organization for our IT-enabled best practices. The ECRI Institute published a deep dive on opioid use in the acute care setting and featured our MOS case study as one of the best practices to decrease risk and improve monitoring in the inpatient setting. ECRI Institute is a nonprofit organization, and it's dedicated to bringing applied scientific research into healthcare to uncover best practices to marry the experience and independence with the objectivity of the evidence-based research.
So what will it cost you to implement MOS at your facility? Let me repeat that sentence, sorry. What will it cost you to implement MOS at your facility? The numbers above are based on the average salary for a registered nurse in the state of Michigan from topregisterednurse.com, and also based on the average salary for an associate analyst off of Indeed.com. We put in, for project planning, 120 total hours at a cost of nearly $4,000, committee work of 20 total hours at $665 an hour, or $665, live and online nursing education per nurse at 1.5 hours each, costing $49,845. Go live support, total of 40 hours, $1,329, and EMR analyst time of about 60 hours at $1,549, coming to a total of implementation cost of $57,375.
So what are the lessons that we learned? We learned that if you involve your frontline staff at the beginning, that you will hopefully develop an army of motivated individuals who have a sense of ownership of the problem and solution. So although it sometimes is resource intensive, if you can involve those frontline staff in the literature review and the data analysis, that you will have a return on investment that is great. Additionally, we want to partner with our IT team at the beginning of our implementation versus pulling them in near the end. They can help us in many ways that we don't even know as far as time savings with build. We know, or we learned, that one-time education and training is definitely not enough. It's not sustainable. So you need to have an ongoing education competency plan as well as orientation. We learned that we need to have a solid go-live support plan, an implementation plan, and that also includes that we needed to have reports and audits available so that we could coach and mentor this new process and this new workflow. We also needed to have clear expectations and accountability, which came from having the reports available to the managers and our project champions, as well as having a policy in place and required documentation. Thank you.
Thank you very much.
Okay, I would like to thank our speakers from Sparrow Health for joining us on this webinar today, and remind our listeners where to go find more quality Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. Again, that's hims.org/Davies. Thank you and have a good day.